Hello, and welcome to the Real Health Podcast. Today's episode might sound a little bit different because I want to tell you about our Cancer Care Reimagined speaker series. When we began planning our 25th International Conference on Human Functioning, Dr. Ron Hunninghake sat down and created his dream team of speakers. Now, we reached out to all of them, and we were so delighted that they all said yes. These speakers are leaders in integrative oncology, functional medicine, and research who are truly shaping the future of cancer care. Each week leading up to the conference, we'll feature one of these extraordinary experts right here on the Real Health Podcast. They will be sharing insights, innovation, and inspiration to help you reimagine what's possible in cancer care. Now, this series and the upcoming conference and gala would not be possible without the generous support of our presenting partner, Empower. Did you know that Empower is the most advanced compounding and 503B outsourcing facility in the nation? They are licensed to serve in all 50 states, and they are deeply committed to improving access to safe, affordable, and personalized medication for the patients, providers, and caregivers who rely on them. Their belief is simple but powerful. Behind every order is a person in need. And with that knowledge, they approach everything they do with compassion, innovation, and a drive for excellence. We are so grateful for their partnership and their support of this important conversation around reimagining cancer care. Now, if you're looking for tickets, they are on sale now, and you can go to our website at cancercarereimagined.org. You can also find tickets for our 50th anniversary gala at cancercarereimagined.org/gala. Now, these links will be posted in the show notes below. We hope that you will join us here in Wichita this November for both unforgettable events.
I just want to tell everyone, I'm Dr. Ron Hunninghake here, Real Health Podcast. We've got one of the most amazing, there's a lot of amazing human beings on this planet, but here's a really special one. Dr. Nasha Winters, a native Kansas girl. My favorite saying, if you want something done, ask a farm girl to do it. I don't know if you actually grew up on the farm, did you? Yep.
Yeah.
So Nasha, for those of you that maybe you haven't heard of her, but you need to hear of Nasha Winters. So Nasha has worked as a naturopathic pioneer in the field of cancer in terms of helping open people's minds to the idea that cancer is just not a thing. It's not just a tumor. It involves all the various facets of what it means to be human. And I think a lot of people intuitively get that about cancer. They even say that there's a cancer in our organization, there's a cancer in our politics. Well, first of all, welcome. But tell me, what is it about cancer that you've learned that everyone really needs to know?
Well, first of all, I'm so honored to be here. You're right. Like, there's something about getting back to your roots. There's something about, one of these days I get to tell the story about really my deep roots into Riordan Center and all the pieces here. It's pretty beautiful and sort of accidental, which you and I both know is not accidental. But as you alluded to right before we started recording, you stumbled upon one of my websites and was looking at my personal journey on the cancer hamster wheel, if you will. And for me, what I have personally learned for myself and what I've experienced with the tens of thousands of patients I've had direct experience with and the tens, if not hundreds of thousands indirectly, is that number one, it's unique to each and every one of us. Like, that's one thing that we get wrong in standard of care, and that we kind of just qualify or classify it as it's a particular stage, it's a particular tissue, and therefore it gets this particular treatment. And yeah, some people will respond to that, but most of us need a lot more. So I think that's one of the big things. The other thing that this sometimes is a trigger warning, I should probably say this ahead of time, but I personally do not perceive cancer as an enemy. So a lot of our ethos, we started calling it the war on cancer in 1971. But of course, that came out of a global sort of ethos around war. We'd come out of 2 world wars, the Korean War, Vietnam War was still raging. And so I think that there was like a collective understanding to use that kind of language, but it's stuck. And it's one that I think, unfortunately, in my opinion, my experience, people forget that cancer is us. And so when we wage war on it, we wage war on ourselves, and we literally do that. The therapies we utilize do just that. That's their job, is to decimate, the field, if you will. And that's by design. So great. They do a great job with it. But again, we can and should be doing more. And so for me, I think the third take home of 34 years on this journey is that cancer is just a messenger. It's just telling us there's something amiss in the terrain.
It's a wound. It's
Yeah.
a wound that we suffer. And instead of looking for what is it that we need to heal the wound, we attack the wound.
Yeah.
I wonder if that's going to make the wound worse or not. Yeah. Yeah. So I've also been amazed at how, in talking with you on several occasions, how very often the wound itself is not just physical.
Oh,
Be more often than not emotional or relational or self-inflicted, because you were not worthy or you did something bad, and so now you have this wound and God is punishing you for this, and it may not be that at all. Maybe it is a wound, but maybe it's not that you did something, but you have to forgive something.
oof, that gives me chills. Yeah, that's it's interesting. I believe, have you guys had Dr. Kelly Turner on your program?
Yes, we have. Yeah.
I thought I remembered that, and
Yeah, I love her book.
brilliant. Right.
Books.
Her 2 books now. And, she actually wrote the foreword for my book, The Metabolic Approach to Cancer. And I think we resonated so much because she highlighted this sort of 9 is where it started, now 10 factors
Right.
of people who are able to meet a very aggressive process and overcome it without a standard of care intervention. So some people call those spontaneous remissions, and she dug deeper and realized there's nothing spontaneous about them. But what I love that she's really put the research behind, Dr. Ron, is that she has shown that there's about 3 tangible things that we can do, right? Diet, lifestyle, exercise. Those are all things that you adjust those, even changing in one direction or the other. If you were over exercising, lower it. If you were vegan, maybe bring on some animal protein. If you were carnivore, maybe bring in more vegetables. Like anytime you shift those tangibles, you can make some headway, but you don't really get very far until you deal with those 7 non-tangibles. And so your listeners might go back and have a listen to those, but specifically things around, like, what are your belief systems? How safe do you feel in the world? Do you speak up for yourself? Do you advocate for yourself? Do you deal with your traumas? Do you have a spiritual practice? Those are the things that we as clinicians can't do for you. And they're the most important foundation, that then when we bring in some of the tools like the IV vitamin C or the mistletoe or the dietary change or the supplements, they need to have something to land in that can be received. And if you're not tending those other 7 intangibles, there's really nothing to land in.
I'm going to jump ahead and give you, I'm going to be talking about at our conference. We're having a wonderful conference coming up here in November, the first weekend in November. And I'm going to be talking about the 3rd medical revolution. We're talking about cancer care reimagined. But to do that, what I came across in my thinking is that the approach that we're taking in medicine now is basically left brain. It's the left brain kind of working with the cancer, okay, and we've got to attack it like it were an infection or something like that. Okay, but then integrative oncology, which you've been one of the stalwarts of it. We're now bringing our right brain into this, the holistic perspective and all the features that you just mentioned. And what's been missing is the dialogue between them. That's the corpus callosum. And it's no wonder that you are at the center of this, because women have a bigger corpus callosum than men do, and they are able to get both sides of the brain working together. To me, this is what I see as integrative oncology's goal, is to get both sides talking to one another so that we can make better inroads into this horrible disease.
Oh my gosh. Yes, sir. I mean, I love that. And I love that. I remembered about that concept of the bridge, but I don't think I remembered women having such a larger one. So that's really fun. And I cannot wait to hear the conversation you carry this, even further. when we're all together in November.
Yeah. But I mean, I think what I'm going to say is it took a woman to really get
Uh,
it. And you've got it, and you've lived it 34 years. Now, I will have to say, Dr. Hugh, when I listened to your podcast, you said a number of Dr. Hugh things. So I think he did have an impact on you. You used to come out here and have lunch with him.
yeah, I was
Dr.
16
Hugh
years
Rare.
old.
Yeah.
Yeah, 16 years old. I was gosh, I must have been sophomore, junior at Southeast High School in Wichita, Kansas. That's where I went to school. I was a Golden Buffalo. And I went through my very vegetarian days, and finding a vegetarian meal in Wichita, Kansas in the late 1980s was not easy. The only place where I could find a very plant-forward meal was at the Riordan Center. And the funny thing is that my grandma and all my very like kind of conservative family members, including my mom, kind of warned me that that place might be a little too new agey or a little too on the cusp. And so I had to kind of sneak over to go and have those meals. I had to like hide my interactions. And a couple times I showed up in a few Fridays in a row. And this gentleman started joining me at my lunch and started chatting. And he just introduced himself as Hugh. I didn't know anything. I didn't know anybody. I was still before a couple years out from my own diagnosis. And he just started having these conversations, like curious about why I was there, curious about, he started teaching me the concept then of the the living learner, the co-learner
Turner.
aspect that you guys drilled into me at a good young age, which I still carry through today. So yeah, I love these stories.
Yeah. Hugh was innovative in his thinking. He was a psychiatrist. Interestingly enough, I wonder if some of what you became, some of that, I mean, obviously we're the total of our life experiences, but he did have some radical points of view in the sense that who we are is not just who we are. I mean, it's what we eat, how we sleep, what environmental factors are at play there, the importance of measuring things. Just that simple. That was the whole concept of functional medicine is measure, measure, measure. But the co-learner, I think, is one of the best ones because I remember in your story, the doctor that his daughter was your
Yeah,
age, and he had to
yeah,
tell you that you had end of life
yeah.
ovarian cancer. Yeah. Did you ever get back with him again? Do you?
Because he was a visiting doctor. And of course, at that time, that kind of shot me out of my body. I wasn't thinking about maintaining those relationships until many years later. And I did try to find him
Hmm,
years later and never did. And I always hope and pray that this man has stumbled across my story somewhere
hmm.
and will reach out himself if he's still around, or someone who and maybe his daughter will hear this message, because I'm sure he went home in those days after and had to process that, and had to hug his daughter a little tighter in those moments. But he was a traveling ER doc. He was coming through. He wasn't a permanent doc at that time. And so it was a couple years before I thought about even looking for him, because I just didn't think, first of all, I didn't think I'd be here, but I also just didn't think about that. It's like how hindsight's, 2020, especially when you're 19, you're not thinking about, oh, this could be a good story someday, especially in 1991. I think today, maybe people going through this, they recognize that they can have kind of a living journal experience, a social media living journal blog experience with it. I wasn't there. I didn't even think of those. I journaled like crazy. That was part of my healing, I think, as well. But it wasn't something public at all. In fact, I was very, very private with my story until about 2012, in fact. And so it was just an interesting thing. But I would always, man, I would love to run into him or his daughter. I've definitely run into a few of the other doctors who saw me at that time, one of which completely it changed their entire life and their entire practice.
Was he the first doctor that you felt cared for you?
You just gave me such goosebumps. He was so, because I'd been coming for months, like and they just kept treating, like it was pretty much they'd had the script pad ready when they would see me come in. They'd already made up their mind to who I was and what was going on. They didn't ask further questions. They discounted everything I said. They just saw me as a histrionic, drug-seeking teenager. They knew my history of IBS and rheumatoid arthritis and endometriosis and PCOS. So they just kept saying, it's just more of that. Here's another script. he had never seen me before. But when I walked in, because he had no first impression, he didn't see polycystic ovarian, or he saw someone who was severely malnourished, who had a huge abdomen that didn't look like ectopic pregnancy or pregnant, like something was off. He saw that my coloration, I had been unconscious for a period of time, put on the pulse ox and saw that I was in the 70s. Like he saw me and then responded by getting different testing done that had ever been done. And that's where the story changed. That's where this person was, oh my gosh, again, I have such compassion. I mean, I think I've told the story, like I comforted him. He was so just a blubbering fool, poor thing, coming in to tell me that because it was just too close to home for him. But yeah, this man saw me and he was so precious and so gentle with his delivery, the best you possibly could be. And I'm grateful that he had a daughter my age so he could think about how would he say this to her.
I see you, the whole you, not just your disease, but how this is going to impact your life. And I think one of the other things you told me one time is that you had so much fluid in your abdomen that you couldn't even eat. And so that you ended up doing a fast. And that was the fasting that maybe kind of turned the tide.
Absolutely. So, Doc, I, of course, had the ascites, and I know you guys have dealt with a lot of patients dealing with that. It's just this fluid buildup. It can sometimes just be caused by inflammation, but it can also be caused by a malignant process, so a cancering process. And for me, it was on the malignant side of the coin. So basically, fluid ended up in places where it shouldn't be in my belly, outside of the containers that it should be, and caused extreme distension, extreme discomfort, but also push organs and things around. So it created kind of a change in my real estate, if you will, of taking anything in. But then I had a complicating factor as well, as I had 100% bowel blockage in addition to that. So nothing to come past, to and through if I swallowed it down. And then the pressure that the ascites caused, any amount of drinking behind literally a few sips of water or warm tea would make me throw up or have such agony that I wished for death. I mean, it was so painful. I can still remember how painful it was. And so I could not physically eat. And Doc, I tell folks this and they never believe me. They never believe me, but I meet dozens and dozens of people like me all the time. I did not eat anything solid at all for 2.5 months. And it took me probably 6 weeks of that to, maybe the last month is when I started trying to play with small amounts of broth or various herbal teas that had any flavor, because I was also very nauseous with it. And I also had no appetite because I had something known as cachexia, which is a metabolic muscle wasting that also turns off hunger signals in your brain. So it was very like anything didn't sound good, didn't feel good. I didn't feel hungry. It was just this crazy process. So for me, that was, to your point, likely an accidental lifeline.
Yeah.
And, our colleague, Dr. Walter Longo, just published this year in 2025 his book, Fasting Cancer.
Yeah.
He's been, I mean, I started hearing his research over 15 years ago, a good 15 plus years into my own journey, to realize that actually what I was doing was, in fact, debulking, making the tumor smaller, lowering all the inflammatory drivers. So these cytokines, it was like probably lowering those interleukin 6 and 8 and whatnot. It was helping my body override the angiogenesis. And so angiogenesis also leads to that fluid buildup, which is driven by inflammation and metabolic dysfunction. So I wasn't feeding it. So I wasn't giving it sugars and other fuel sources, and not eating also took the burden off that the inflammation could subside. And then slowly over time, in the first few months or first few weeks, I was having to get drained every couple of days just to be comfortable. They were just making me comfortable as I died. And then they needed to drain it less and less and less and less, further and further apart. And in about 3 months, I didn't have to go back in for any more drainings. And they didn't know what to do with me.
Yeah.
I didn't know what to do with me. Yeah.
You were your first metabolic patient. You were the first patient of the metabolic approach to cancer, because this is surely a case of the metabolic treatment of cancer. Just what, and it happened, you know, God.
serendipitously. Yeah, exactly.
So it happened, but so much can be learned from that in terms of what you went on to write about in terms of metabolic approach to cancer, and that has become now kind of a standard of care, and everyone's adopted that term. And you know, where do we go from here, though? Where do we go?
Ah, man, I feel so excited. I can even remember speaking at your IVC symposium in 2018, right? And even these ideas were, I mean, they were finally starting to integrate into the community, but people were just sort of still, we were still considered somewhat fringe. But just in 2024, a paper came out, I believe Nature, came out showing that perhaps the somatic mutation theory is finally dead. And that the theory of current,
Right.
is the metabolic theory. So now it's like we get to all come out of the closet and talk about it at the table together. So when you say what's on the horizon, I feel like we're just getting started. I'm super excited to see where research can go. I'm super excited to be collecting more data so we can publish on more case presentations. I'm excited to see what new, maybe novel formulations or novel delivery systems or even novel testing can be done in this field, because metabolic oncology is a field of medicine now. And so I feel like the sky's the limit. I feel like we're just finally getting started.
Yeah, and I saw that you were pretty much involved with Mark Lintern in terms of cancer resolution and the whole notion of fungal link to cancer, which in 2003, I gave a lecture called The Fungal Link to Cancer because Dr. Milton White came and visited Dr. Hugh for a week.
What?
Dr. Milton White was the first doctor to make that association. And it
Wow.
made total sense. We ended up doing a lecture on it and then promptly forgot about it,
Well,
unfortunately.
but not unfortunately. How cool that you could go back into your memory bank and remember that conversation
Yeah.
and how relevant it was then and how relevant it is now.
Yeah. I don't know where it all fits in. I know there's a lot of people thinking about parasites and fungi and bacteria and viruses and whatnot. So, but are they there for the simple reason that the immune system is so suppressed and they're basically just doing their job? This person's dying and we got to move in and do our job now.
Yeah.
Not,
That's questions I have with Mark, is I think there's a lot to what he's saying. Is I definitely have no doubt that this fungal etiology or expression is driving it further. It's another terrain driver, if you will.
Yeah.
I'm not certain still, and I think, but this is what I'm excited about. I think this is on the horizon of it. Can we prove that it is in fact the starting point of cancer? Because Mark was basically able to say that the metabolic theory touches all the hallmarks but one, and the fungal theory touches all the hallmarks, including the one that metabolic misses. But the really interesting thing to me is how much the fungal and the metabolic are absolutely in tandem, and even kind of cross-pollinating and integrating with each other. That if I don't, with a patient, deal with their underlying fungal infections or dysbiosis or parasitic infections or co-infections, we can kind of keep in the same cycle of cancering again and again and again. So to your point, also all these amazing things we're experiencing with off-label drugs and whatnot that are really making a resurgence right now. So many of them have that mechanism of action, but I still feel like we have not quite figured it out, because I don't think it's what we think it is.
Well, I'm thinking of German New Medicine and the idea that there's something of something going on, maybe a PTSD type of thing, or some self-deprecating thing that serves as a catalyst in a negative way to set the stage for the immune system to go down, the defenses to go down, and maybe this tendency for the body to start disintegrating gets improperly triggered, and then you get into a downward spiral. And so unless you go back and deal with all those questions in terms of why am I here and all the different things like that, you're not going to solve the problem just by attacking the cancer. Obviously, we've seen that over and over again, but but the process of doing that is more than what the current medical system can sustain. And so now enter in integrative oncology, where we take the time, we go into that in-depth process, but looking at everything, not leaving anything out. We have to look at the whole picture.
Exactly. We really truly can't leave any stone unturned, because what may be happening in my body is going to be so different than what's happening in yours or Dr. West's, or, like but like we all are so unique in our life experiences, our life exposures, even the way our bodies interpret that information, so it's like we're all just receivers of information, and specifically the little organelles within our cells are the ultimate receivers. The mitochondria literally gather like light, sound, nourishment, water, toxins, thoughts, all the things are input. And then if it's lucky enough, then it translates that information, and then it sends signals or communication out to the surrounding organelles, cells, tissues, organs, etc. And so if you can see, I guess, for the listener to understand that there's a few places along the road that it can get in trouble, that it can miscommunicate or misunderstand or mistranslate or misgather the information, or it's just getting too much information into the body in a variety of different ways. And so that to me is what's so exciting today, and that we're starting to understand how best to support the organism, the extracellular matrix, the mitochondria, the tumor microenvironment, to change the environment that prevents cancer from having the stronghold. So it may be that cancer's still on board, and you can just put it into kind of a pause button, right? And you can live a long and healthy and vital life with cancer. I'm one of those people. I have thousands of those people in my world. You can be someone who just sort of on the accidental goes completely in remission. You maybe never see that again. Great. You could also be someone who goes into remission, and a few months or years or even decades later, it's back with a very different personality than the first go. And so this is what I think is so extraordinary. Standard of care today is just starting to scratch the surface, because they've not been asking the wrong questions all along. But the folks from the functional and the integrative and the naturopathic and the vitalistic fields, we've been asking these questions since the get-go. And I feel like we're finally all coming together, and there's much more of an opportunity for a common narrative, which means a common, like, asking different questions and moving forward faster together.
Yeah. Tell our audience what you're doing to train people, because you're training doctors, but you're also training now a whole group of people who have this insight. They don't necessarily have a medical degree, but they want to pitch in and help. So explain your program to our audience.
Sure. When I was in private practice for 17 years, I had a ton of amazing patients that would come from all over, and they'd spend a few weeks with us. They needed so much hand-holding that I had a colleague, or a woman in my office, that we called her our patient concierge. And she was like the magic sauce for everything we were doing, because I might be doing the assessment, but she was the person helping explain why they were doing anything, or show them how to do it. She was there to answer those questions. So in that, my colleagues always said, "Why do you have better outcomes than we do?" And I'm like, well, I think I have this sort of seamless system of container of support around the patient. And so that model worked for me. And when I got out of private practice and decided to kind of work more as an educator, what happened is I realized the patients were savvier than the doctors at that point. There was a lot of resources for the patients to get educated. There were none for the clinicians. So in 2020, I started with a group of 12 committed, crazy, we'll just call them what they were, because they were so wild to say, yes, I'll do it. 12 doctors to say, I'll take you through the process. I'll download my brain in you and see what you can do with it. And out of that, I was able to teach the methodology of this sort of test, assess, address. And we've gone from 12 clinicians in January 2020. We just started last week our 12th cohort of clinicians. We are encroaching 1,200 clinicians and allied health professionals in 46 countries to date.
And I'm one of them.
I know. You have a whole posse over there.
We really do. So
Such a joy.
we're so grateful. But it doesn't even have to be a clinician, though. It can be
And that's what happened after about a year and a half. We had all these doctors who were like, this is great, but it is a lot. There's no way I can do all of this. And then we turned our attention towards training what we call patient advocates, which would have been my first iteration when I called a patient concierge. So we trained them in a parallel path. So they're learning the same terminology and whatnot, but they're learning like what is the role of an advocate versus that of the clinician and how can they lean in and support each other. So really the patient is in the center and they win because the advocate is the handhold between the patient and the clinician, and they are who allow like prevents all the balls from being dropped, and they can be the voice for the patient when the patient's unable. They can help ask and answer questions when the doctors are unable, so it's all in this really powerful way. We now have hundreds and hundreds of those in our midst as well, and we even just began our first cohort. We're getting ready to start our second cohort the end of September of what we call our AIM, our Allied Integrated Medicine group. So these are the folks that aren't able to maybe they can order labs, but they can't order imaging, they can't prescribe off labels or chemo or any thyroid medication, but they have a lot more medical background than say an advocate. So these are your nurses, your RD, your nutritionists, perhaps your physical therapists. We just created this because we had this kind of huge gap that was in between. Because a lot of practices today in standard of care, you have these like allied health professionals, that you've got your MD, your PA, your MP, and then your nurses. We're setting up the same kind of structure within the integrative oncology community because it honestly takes a village. And so it's been really a joy to bring advocates, allied health professionals, and professionals together, medical professionals together, because we all bring something to the table that we need. All of us do.
The head of integrative medicine at MD Anderson wrote a book called Anti-Cancer Living, where he looked at all the various lifestyle types of things that helps you prevent cancer, and maybe even get over cancer. But the number one thing that he found epigenetically was what he called connectivity. So when people are connected to other people, and especially people who feel empowered and who want to help and know what to do and can be resources to this patient, that's a good impetus for survival.
Love it. I'm guessing you're talking about Dr. Cohen and his work.
Yes.
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 So brilliant, because that's just it. And we so, I think, downplay that role. But even, gosh, in the 80s, was it Bernie Siegel who was doing research? Right? Good old Bernie.
Yeah, he spoke at Dr. Riordan's conferences. Yeah, and we actually, matter of fact, for many years, everyone had to draw their illness.
I don't have it on the wall right now. My husband heard him speak. We were at one of the conferences, and he was having us, all the doctors, do that. And we actually framed Steve's because Dr. Bernie grabbed Steve's as an example and went through it. And it was shocking how accurate he was. He knew exactly what was happening. And that man, he wouldn't do surgery on these little kids if they couldn't write a good outcome, draw a good outcome.
Right.
Revision it until it was a better outcome. And then guess what? He had amazing outcomes. But he's also the man who really pushed into the research around this concept of community. Those patients, there were two things he came up with through his research. One of the answers is the bigger pain in the ass you are, the better your outcomes. So basically, be proactive, ask questions, be that kind of an antagonizing patient, because you have to speak up for yourself and advocate for yourself. So he showed those patients do better, live longer. And the other group were those who joined some kind of a support group. So there's that community, that connectivity, so they could all have had, no matter what their stage, these breast cancer patients that were involved in a support group versus those who weren't had a far longer overall survival. And so those were the things that just why do we not get excited and offer these conversations even more? That was back in the 80s, for crying out loud.
Yeah. Well, and your insight about patients carrying shame or carrying PTSD, that I think I asked you this directly, how often do you see that? And you say, always.
Always. I honestly cannot think of, maybe if someone says no in the beginning, after we start to work together.
To admit it. Yeah.
Or they were just so honestly, because we take such a deep, if you've seen, such a huge intake. 54 pages, right? And we
That's
take this in and we're also looking at their adverse childhood event scores. I mean, I just did a case this past weekend where I was sitting in with one of our colleagues and going over this case, and I happened to be there with the gentleman, and we're going through his case. And he does not like he's got his ACE score and he's telling us it's a 0. And then we find out his parents got divorced when he was 11. The parents divorced after losing a child, so a sibling that was his like closest sibling. And I'm like, they're the lack of even awareness that that would even be something to say a major loss or change in this part of your childhood. At 73 years old, he didn't even think about that. And then what was really hard in his cancer. So I love that you brought up Dr. Hammer's work in the German New Medicine. What was really interesting is a few years before his diagnosis, they lost a child.
mm,
And so, yes, a grown
suppress that.
child,
You
but a child.
suppress all that.
Yes. Didn't even, and it had to be like teased, like it was like an accidental, almost like, oh yeah, we lost a child a couple years ago. And you're like, what?
What?
Excuse me? Yeah. So we humans, we push those things away. They're often too tender to even approach. And so there's ways of which we as clinicians can kind of get there eventually, because when we're really tuning in ourselves, we feel it. We know when that is in the field, as esoteric as that may sound. You can feel that discourse or that lack of, resonance in the field. So it's just really obvious when someone is not like remembering or feeling into or having awareness around some of these big drivers in their lives.
So we're imagining a new kind of way of helping our cancer patients. And first of all, in a sense, joining them. I mean, my father died of cancer. My mother had cancer. My brother has prostate cancer. We've had one of our kids has had a melanoma. So it's out there, it's there. So until we can get the world, not that we do it, but if people would just open up their minds and say, and we could really make something happen, because there's so many young people getting cancer. The fear level is so high. So if we could take that fear away and say, hey, you've got the power to get this better, but it's a process. It's not just a hopeful thinking. It's a process. It's a science. But it's a different kind of science than what it's once again integrating the left brain, the right brain, and getting the connection of the two going.
Absolutely. We used to call, we'd call the practice of medicine. There's something to that, right? That it insinuates that it's not stagnant, that it's dynamic, and that it's ever evolving and iterating. So I want folks to remember that we don't know what we don't know until we know. And that's for clinicians, patients, advocates, caregivers, the whole bit. But then this other part is we also call it the art of medicine.
Yeah.
And the art is what you're talking about. That is the true bridging of the right and the left brain, because there's this deeper listening beyond our observation skills, beyond our main senses. There's a deeper listening of feeling. And today, in the world of telemed and Zoom room meetings, some of that can be lost. I mean, you have to really hone that skill if you're working with patients in this format, because it's harder to miss when you're in person, right? And so for any clinician listening or any patient listening who has a sense that maybe their doctor doesn't fully see them, it's worth making that extra, maybe you go and invest in time with that person at least once, because once you engage in that field even once, it's an easier to stay connected even when there's a screen between you. I think you guys do that well at the Riordan Center. You try and get people there for intensives and, so at least a first time one-on-one to establish. When I had my practice in Colorado, it was the same thing. It's like my first visit I had to do, because there was legalities around, but it was also very much a need to actually know who was in front of me and feel who's in front of me, and for them to feel me. And so then when we would connect again over the phone or over a Zoom call or what have you, there was already that connection was established, and we couldn't, it was more difficult to break.
Nasha, I think we could just go on, but
Forever, love. Yeah. I'm just going to have to come out and hang out with you in November, and I'm very excited.
Great. It's going to be fun. We're going to also have our 50-year gala, which you are going to be receiving a very justly deserved award. And so, but I think anyone that can come should be able to have this sense of amazement that we can do this. This is something that is happening. You were a spark, but now it's turning into a good forest fire.
It's a good one.
And we hope that our conference will be another step in that evolutionary process of people opening their minds and being willing to see that cancer is controllable, but it's going to take all of our resources of healing, not just left brain, but all of our resources of healing in order to get the job done in most cases. So, but thank you for all your work, and thanks for being on the program, and can't wait to see you.
Ditto. Thank you so, so much.
All right.
Thank you for listening to the Real Health Podcast. This episode was brought to you by Empower Pharmacy, the most advanced compounding pharmacy and 503B outsourcing facility in the nation. Licensed in all 50 states, Empower is committed to improving access to safe, affordable, and personalized medications for patients, providers, and caregivers. Learn more at empowerpharmacy.com. If you enjoyed this episode, be sure to subscribe and leave us a review. You can also find all of the episode and show notes over at realhealthpodcasts.org. Also, be sure to visit riordanclinic.org, where you will find hundreds of videos and articles to help you create your own version of real health.